Welcome to the deep dive. Today, we're taking a slightly different approach.
That's right. We've got a set of MSRA pediatric revision notes shared by one of you, focusing specifically on Down syndrome.
Exactly. So our plan is to dive into these notes, pull out the absolute must-know information, structure it clearly, and, make it really high yield for revision.
Think of it as us highlighting the key points for you, walking through the definition, the causes, risks, how it presents, diagnosis, management, all that crucial stuff, straight from these notes.
Making the notes stick. Okay, let's get right into it. Section 1 in the notes is definition. What's the absolute core we need to grasp?
Well, at its heart, the notes define it as trisomy 21. That immediately tells you the genetic basis is having an extra copy, a third copy of chromosome 21.
And that extra genetic material is what leads to the physical characteristics and developmental differences the notes talk about.
Precisely. It disrupts the normal genetic balance.
And the notes mention there isn't just one way this happens, different types.
Correct. The most common, by far, is standard trisomy 21. That's where every cell has the extra chromosome, usually because of an error in cell division called non-disjunction.
Oh, I have non-disjunction.
Then the notes mention mosaic Down syndrome. That's where the error happens a bit later, during early development, so you end up with a mix. Some cells have the extra chromosome, some don't.
A mosaic pattern makes sense.
Yeah.
And the third type.
Translocation Down syndrome. This one's a bit different. A piece of chromosome 21 actually breaks off and attaches itself to another chromosome, often chromosome 14.
So it's not a whole extra chromosome floating around, but the genetic material is still extra?
Exactly. And if the parent carries what's called a balanced translocation, they have the right amount of genetic material just rearranged. They can pass on an unbalanced form to their child, resulting in the extra chromosome 21 material.
So 3 main routes, but the end result is that extra genetic dosage from chromosome 21. The notes highlight multiple malformations, medical conditions, cognitive impairment, but they also stress variability, right?
Yes, and that's a really crucial point they make. The physical features can vary a lot between individuals, and so can the degree of cognitive impairment.
And there was that interesting note about social functioning.
Right. The notes mention that individuals often function effectively in social situations, sometimes maybe better than you might expect just looking at cognitive test scores alone. It's a nuance worth remembering.
Definitely. And the notes also quickly mention the role of primary care supporting parents, initial diagnosis, management, treating common issues, health promotion, sets the stage.
Okay, so that's the what's. Now let's look at the why or how, the etiology, the causes.
We know it's the extra chromosome 21, and the notes gave that very specific statistic.
Yes, the 88% figure. In standard trisomy 21, the notes state the extra chromosome comes from the mother's egg in about 88% of cases. That's a key takeaway number.
88%. Got it. And the other mechanisms are those ones we just mentioned, partial trisomy, mosaicism, translocation.
Correct. But a big part of this section in the notes is listing the associated medical conditions. This is where we see the wide-ranging impact of that extra chromosome.
Right, and the notes helpfully group these by body system. Let's run through them. What about the heart? Cardiological issues.
Very common, definitely high yield. The notes list atrioventricular canal defects, sometimes called AVSDs, ventricular septal defects, VSDs, mitral valve prolapse, MVP, and aortic regurgitation, AR. Big structural heart things.
Okay. And ENT, ears, nose, throat.
Hearing loss is a big one. Also recurrent ear infections, otitis media, and obstructive sleep apnea, OSA.
Makes sense. Eyes, ophthalmological.
The notes flag cataracts, refractive errors, so needing glasses for short-sightedness, long-sightedness, astigmatism, and strabismus, which is a squint or crossed eyes.
Gastrointestinal, the gut.
Key things mentioned are esophageal atresia and duodenal atresia. That's the double bubble sign you might see on an X-ray. Also Hirschsprung's disease affecting the bowel and celiac disease.
How about bones and joints, orthopedic issues?
Atlantoaxial instability. That's instability between the top 2 vertebrae in the neck. Really important to know about. Also scoliosis, curvature of the spine, hip dislocation risk, and various foot deformities.
Right, that neck instability sounds critical. Endocrine system. Hormones?
Hypothyroidism is very common, hence the screening. The notes also mention an increased risk of diabetes.
Neurological and psychiatric.
Well, learning difficulties are characteristic, as the notes state. Potential behavioral problems, too, and seizures can occur. And importantly, that increased risk of developing an Alzheimer's-like dementia, often at a much earlier age.
And finally, hematological, blood-related conditions.
Increased susceptibility to infections is noted, a significantly higher risk of childhood leukemia, unfortunately, and a specific thing in newborns called transient myeloproliferative disorder.
Wow, okay, that's quite a list. Grouping them by system definitely helps to mentally organize it.
It really shows how systemic the effects are.
So that covers the potential associated conditions. Now, who is most at risk? What are the risk factors mentioned in the notes?
The single biggest factor highlighted is advanced maternal age. The notes are very clear on that.
And other factors.
A family history, like having a previous child with Down syndrome, and also if a parent is known to be a carrier of one of those balanced translocations involving chromosome 21 that we talked about.
Right, and the notes provide some pretty stark numbers on the age risk, don't they, using UK data?
They do. Per 1,000 live births, the risk starts relatively low. Under 20, it's about 0.66, 2024, 0.70, 25-29, 0.84, 30-34, it creeps up to 1.48.
Okay, still quite low there.
But then look at the jump. For ages 35-39, the notes state it's 4.72 per 1,000. For 40-44, it's 15.22. And for 45 and over, it's a striking 30.71 per 1,000 live births.
Wow, okay. That really does show a steep increase, especially after 35 and dramatically after 40.
It illustrates the biological link very clearly.
So what about the underlying mechanism, the pathophysiology section in the notes?
It's quite brief in the notes, really. It focuses on the core problem, that extra chromosome 21 creates a genetic imbalance.
Which disrupts normal processes.
Exactly. It affects how genes are expressed and regulated, which in turn impacts the development and function of various body systems. But the notes also make a point of saying that our understanding is still incomplete.
Meaning we don't know exactly how the extra chromosome causes every single feature.
Precisely. We know the root cause, the extra genetic material, but the specific pathways leading from that extra chromosome to, say, the facial features or the heart defects aren't fully understood for everything.
Interesting. Acknowledging the limits of current knowledge. What about differential diagnosis? Other conditions that might look similar initially?
The notes list a few other genetic syndromes that might share some features, like Fragile X syndrome, Turner syndrome, and Williams syndrome.
And they also mention similarities like congenital heart defects, which can occur in other conditions too. And just generally, other chromosomal abnormalities might have some overlapping physical signs.
Right. It's about considering other possibilities, although the overall pattern in Down syndrome is usually quite distinct.
Okay. Let's move on to epidemiology. The numbers. How common is it?
The notes give a global incidence range of about 1 in 650 to 1 in 1,000 people affected.
And specifically in the UK.
Approximately 1 in 1,000 live births, according to the notes.
And they break down the causes, again, by prevalence.
Yes, reinforcing the earlier point. Standard trisomy 21 accounts for about 94% of cases. Mosaicism is around 2.4%, and translocations make up about 3.3%.
And there was a detail about the translocations.
Yeah, an important one for counseling. About 75% of those translocations are de novo. They happen spontaneously in the formation of the egg or sperm. They weren't inherited from a carrier parent.
Good to know. And the notes revisit the maternal age risk with slightly different figures.
They do, perhaps from a different source or just presented differently, but drive it home the same point. Age 20 risk is about 1 in 1,500. Age 30, 1 in 800. Age 35, it jumps to 1 in 270. Age 40, 1 in 100. And age 45 plus, 1 in 50 or even greater.
Same message, different numbers, definitely reinforces the age link. What about the risk of it happening again in a family? Recurrence risk.
This is key for genetic counseling, and the notes give specifics based on the type. For standard non-disjunction trisomy 21, the 94% majority, if the mother's under 35, the recurrence risk is quoted as approximately 1 in 100.
So slightly higher than the general population risk for her age, but still relatively low overall.
Yes. But for Robertsonian translocations, which are about 5% of cases, the risk is significantly higher if one of the parents is identified as a carrier of the balanced translocation.
What makes sense? And mosaicism.
Mosaicism, about 1% of cases, generally has a lower recurrence risk, though it's complex to predict precisely. The main takeaway is the type matters hugely for recurrence risk.
Absolutely. Knowing the specific cytogenetics is vital.
Okay, let's shift to what it actually looks like, the clinical presentation.
The notes list many common features, things you might observe. Some are quite characteristic facial features.
Like the upward slanting eyes, oblique palpebral fissures, and the epicanthic folds, those little skin folds at the inner corner of the eyes. Exactly. Also, cognitive impairment and developmental delays are core features mentioned. And hypotonia, that sort of floppiness or low muscle tone, often noticeable right from birth.
What else do the notes list?
Low set ears. which might also be folded or have narrow openings,
Yep.
stenotic meatus, a relatively small mouth, often with a tongue that seems a bit large or protrudes. In babies, sometimes loose skin at the nape of the neck,
And the hands and feet?
a single deep crease across the single palmar or simian crease is common, though not exclusive to Down syndrome. Also, a wider gap than usual between the big toe, the hallux, and the second toe.
And brushfield spots.
Yes, small white or grayish spots that can sometimes be seen around the edge of the iris, the colored part of the eye. Visualizing these features can really help cement them in memory.
Definitely. The notes also highlight key checks needed for newborns, right? Neonatal assessments.
Crucial screening points. Screening for congenital heart defects is absolutely vital, usually with an echocardiogram.
Okay. What else?
Maybe a radiographic swallowing assessment if the baby's having feeding difficulties.
Yeah.
Checking the eye's red reflex carefully to screen for congenital cataracts.
During screening.
Essential. Often done using methods like brainstem auditory evoked response, BAER, or otoacoustic emissions.
And blood tests.
Screening for thyroid problems, TSH, and free thyroxine levels because hypothyroidism is common. And a complete blood count, looking out for those potential hematological issues like the transient myeloproliferative disorder.
So a standard set of checks tailored to the known risks. And the notes mention ongoing annual health checks, too.
Yes, emphasizing that lifelong monitoring and proactive care are needed.
The description of diagnosis also reiterates the developmental side. Mild to moderate intellectual disability typically, developmental delays across the board, and sometimes behavioral problems.
And they list characteristic features specifically at birth again, which reinforces the earlier list. Low-set ears, small head, ears, mouth, short neck, almond-shaped eyes, flat nasal bridge, single palmar crease, short stature, hypotonia. Sort of a head-to-toe reminder.
And this section lists again the conditions they're at increased risk for over their lifetime. Seems like some overlap with the etiology section.
It does overlap, but framing it here perhaps emphasizes the things to monitor for long-term. Congenital heart disease, vision-hearing problems, hypothyroidism, GI conditions like celiac, blood disorders like leukemia, mental health issues, and that significant risk of early-onset Alzheimer's, typically from age 50 onwards.
Got it. Okay, so that's how it might present. How is it formally investigated and diagnosed according to the notes?
The definitive diagnosis relies on genetic testing. The classic method mentioned is karyotyping.
That's where they look at the chromosomes under a microscope.
Exactly. It allows them to visualize and confirm the presence of the extra chromosome 21. Another genetic test mentioned is chromosomal microarray analysis, or CMA, which is very detailed and can also identify the extra genetic material.
And what about before birth? Prenatal testing. The notes differentiate screening from diagnostic tests here.
Yes, that's an important distinction. Screening tests estimate the likelihood or risk. The notes mention non-invasive prenatal testing, NIPT, which analyzes fetal DNA fragments found in the mother's blood.
So it's just a blood test for the mother?
Right. And prenatal ultrasound is also used for screening, looking for markers like increased neutral translucency fluid at the back of the baby's neck.
And specific screening protocols mentioned.
The combined test, typically done around 10-14 weeks, which uses maternal age, specific hormone levels in the mother's blood, and the neutral translucency measurement from the ultrasound. And the quadruple test, another blood test done a bit later, usually 14-20 weeks.
So those give a risk score. What about tests that give a definite yes-no diagnosis prenatally?
Those are the diagnostic tests. The notes list chorionic villus sampling, CVS, done around 11-14 weeks, where a small sample of placental tissue is taken. And amniocentesis, usually done from week 15 onwards, involves taking a sample of the amniotic fluid surrounding the baby.
And these carry a risk.
Yes, and the notes explicitly state this. Both CVS and amniocentesis carry a small risk of miscarriage, quoted as up to 1%. That's a critical piece of information for parental counseling.
Absolutely. 1% risk. And if the diagnosis wasn't made prenatally, or there's doubt after birth?
Then a postnatal karyotype is done on the baby's blood for definitive confirmation.
Okay. So that's diagnosis sorted. Moving on to management in Section 9, the notes are clear. There's no cure for the underlying genetics.
No, the focus, as the notes say, is very much on enhancing the individual's abilities and managing all those associated health conditions effectively throughout their life.
What are the key pillars of management mentioned?
Early intervention is highlighted, getting therapy started early to support development, providing appropriate educational support tailored to their needs, comprehensive medical management for known issues like heart problems or thyroid dysfunction, and promoting a healthy lifestyle overall.
And it takes a team, right? The notes list the professionals involved.
Definitely a multidisciplinary approach. Physiotherapists for motor skills, speech and language therapists for communication, occupational therapists for daily living skills, plus various medical specialists depending on the individual's needs, psychological support, educational professionals, and importantly, genetic counseling for the family.
Thinking about that whole team helps picture the scope of support needed. Now, what about the long-term picture, prognosis?
The notes point out a really significant improvement in survival over the last few decades,
Largely due to better medical care.
especially better surgical repairs for congenital heart defects. That's made a huge difference.
What are the specifics on lifespan?
Many individuals now survive well into adolescence and adulthood. The notes give a median age at death in the mid-50s, with some living into their 60s, a big change from decades ago.
That's really positive. Any challenges mentioned?
Fertility support is noted as a potential challenge for individuals who wish to have children.
And leading causes of death.
The notes list respiratory infections, ongoing cardiac issues, the development of dementia, and childhood leukemia as major causes.
Interesting detail about other cancers, though.
Yes, the notes mention a generally low incidence of other types of malignancies, with childhood leukemia being that specific exception where risk is increased.
And cardiovascular disease risk.
Also interesting, generally lower than the general population, but the notes say it does increase after age 50, reaching about 13%.
And the overall message on prognosis.
It ends on an important positive note. With the right care and support, individuals with Down syndrome can, and absolutely do, lead fulfilling lives.
That's crucial to remember. Finally, the notes have a section just summarizing the main complications. Feels like a recap.
Yeah, it largely reinforces the health issues we've discussed, but lists them concisely as the key complications to be aware of over time.
So that includes the increased risk of congenital heart defects.
Susceptibility to respiratory infections, hearing and vision problems, thyroid dysfunction, gastrointestinal issues like celiac disease, and that elevated risk of Alzheimer's disease. Kind of the greatest hits of potential medical challenges.
Right, a final checklist of things to monitor.
And that covers all the key sections laid out in these revision notes.
So we've journeyed through the definition, the causes like non-disjunction and translocation, the big risk factor of maternal age, how it presents with those distinct features and developmental patterns, the investigations from screening to karyotaping, the multidisciplinary management, and the much improved prognosis, all straight from the notes.
We've tried to pull out those core facts and figures.
And one point that stood out to me right back near the beginning was that note about social functioning. How individuals with Down syndrome, despite maybe scoring differently on cognitive tests, often function really well socially.
Yes, that nuance about the person beyond the test scores.
It makes you think, doesn't it? It prompts a question, maybe for you listening. How do we really define ability or success? These notes covered the medical side thoroughly, but that point, combined with the prognosis mentioning fulfilling lives, makes you consider what contributes to that fullness beyond just the clinical picture.
It's a good point for reflection. It adds that human dimension to the factual revision.
Exactly. Well, we hope this deep dive into these specific Down syndrome revision notes has been genuinely useful, breaking down the information in a way that helps it stick for your learning or MSRA prep.
If this style of breakdown works for you, remember there are more dedicated MSRA resources available over at PathMSRA.com.
And also check out freemsra.com for additional materials.
We hope walking through these notes together has been valuable.
Thanks for joining us on the deep dive.
We'll catch you next time for another exploration.